Ladies and gentlemen, I'm Brian Durie, and it's my great pleasure to invite you in the next of our Making Sense of Treatment series, coming to you this evening from San Diego, California, which is where the American Society of Hematology are holding their annual meeting. And so this is something that we have been doing for a number of years to bring you the latest exciting information being presented to a total audience at ASH this year of over 28,000 people, the largest ASH ever, I've been told. Joining me this evening, I have a great pleasure in re-welcoming Dr. Joseph Mikhael from the Mayo Clinic in Scottsdale, Arizona.
Thank you, Brian.
And I'm welcoming someone for the first time to our series, so please welcome Dr. Lonial from Emory University, is the chair of hematology oncology there. And we're extremely grateful to Sagar because for those of you who have been looking at our advertisements, you know that Dr. Mary V. Mateos had really intended to be here, but really just unable to be here at the last moment. So thank you so much, Sagar, for jumping in and helping us out. And we really are looking forward to your opinions on these topics tonight. So what are we going to talk about tonight? So I've listed here 6 broad areas where most of the abstracts have been giving updated information, which I think deserves further discussion. And so who should be treated? This is about looking at the testing at the start of therapy and deciding who might be eligible to treat like myeloma or maybe even smoldering myeloma. If you actually definitely do have myeloma, what are your best frontline options heading into 2017? There is a very exciting new abstract being presented about the role of transplant in myeloma, so we will definitely take a little bit of time to focus on the pros and cons of transplant, both single and double. A lot of abstracts this year, as there were last year, on the role of minimal residual disease, negative results, positive results, and figuring out what to do in both of those situations if the testing is negative or positive. Relapse options, many relapse options, and what we want to do mostly tonight is try to make sense of all those options for you the best that we can. And then of course, what many people come to ASH to find out is what are these new agents that are coming forward in the clinical trials, single agents and combinations, and how do those new therapy options look? What is the most promising? So let's get started with the first topic. When should treatment be started? Well, it's very nice that to my left I have the gentleman who coined the SLIM CRAB acronym, and so over on my top left in the blue box we have the SLIM CRAB criteria, and so this was the latest movement forward where patients with CRAB criteria certainly have myeloma, but now based on the publication of the new diagnostic criteria, the SLIM CRAB criteria, 60% plasma cells, a high free light ratio, and the MRI lesions allow us to define these events, and we're comfortable in treating those patients. Well, we can see for sure that we are. But over on the right, you have patients who do not have those types of myeloma defining events nor CRAB criteria. And those are different levels of risk of smoldering myeloma. And in the high-risk group, what we want to touch on is how secure are we in identifying these high-risk patients sufficient that we would intervene with therapy of some type. The fundamental question will become is, do we want to move those areas in the red boxes over into the blue box, or how do we want to proceed? At the present time, if there is a defined indication of high-risk smoldering, there are really 2 options. And I think I'm very pleased tonight that I have people who are involved with considering both these kinds of options. So there are gentle approaches, and we do have evidence from a randomized study that the gentle approach with RD can be helpful, improving remissions and survival. And then we have trials which are just getting started using a much more aggressive approach where there is the idea to take the opportunity to maybe even try to cure those patients with earlier disease. And so perhaps I'll start with you, Sagar, because you have been quite interested in this gentle approach and in fact have ECOG trial evaluating this. So would you like to start us off with your thoughts on this?
Yeah, I think, when you talk about the gentle approach versus a more aggressive approach, I think that what we're trying to demonstrate with the gentle approach is that you can intervene in the natural history of the disease. Smoldering myeloma is a big grab bag of a lot of different subtypes of smoldering. And on the one end, you've got smoldering that is really myeloma, but it's just happening to pass through smoldering by the time the patient is seen. And then you've got a bunch of patients that are probably actually MGUS, and for some reasons of categorization, get dumped into the smoldering category. And so I think the rationale behind the gentle approach is about understanding that perhaps we can't really define those two groups as well as we think we can.
Right, so until we can, the gentle approach is safer because you don't end up over-treating an MGUS or an early case.
Correct, that's absolutely right. That's
Yeah. So I mean, so what's your perspective on this? I mean,
well, I agree with ActivisM very much that I think, myeloma is such a huge spectrum. We sometimes have to draw artificial lines. And I think right now we've gone from crab to slim crab, and I anticipate over the next few years we'll probably identify 2 or 3 or 4 other groupings that would, if you will, be upgraded or downgraded, depending how you look at it, into myeloma. I'll have to come up with a new acronym.
There you go.
Scrabble and chubby crab and various other things. But
we could end up moving those patients over into the blue box.
Right.
I think
my concern,
I think the red box will go away.
Yes.
Yeah, ultimately, I think it would go away. And then secondly, I do think that we want to look at a natural evolutionary change potential. My little bit of a hesitation with the gently approach, though, is until we're clearly identifying that we can do that, although it sounds attractive that we're not over-treating these individuals, we could be under-treating them and then ultimately breeding more resistant disease, potentially.
Right.
But I do think doing those two things at the same time. One, learning who should really be pushed over into the true myeloma bucket.
Right.
And then trying to see if we can change the natural history. The Icelandic group are doing amazing work where they're trying to screen the whole country for MGUS.
Yeah, so this is our iStop MM program.
The iStop MM program, which of course the Black Swan Initiative has been supporting, which is wonderful. And I think we'll learn about that with time. But in the short term, for patients listening and for clinicians listening, I think we're still at a stage where we're really only treating the slim crab group and maybe upgrading a few more. And then those that are in this questionable area, I think are best to study under clinical trial. But if I have a smoldering patient in my clinic tomorrow, I'm still not treating them. Watching them closely, obviously, but not treating them.
Right, and so just a comment about the Icelandic program, because they are screening and identifying MGUS, smoldering, and myeloma. And coming out of that, as part of the iStop MM program, this cure trial approach will be applied to the high-risk smoldering, but also will be used to treat myeloma patients. So what that means is there will be a direct comparison of using the same regimen in both instances. So I think that's
which will help answer a little bit of that question. Can you change the natural history of the disease by intervening earlier?
Yeah, because I think that's an interesting question. There's a lot of hope that you can, but genetically, smoldering looks very similar to symptomatic myeloma. So if you're making a genetic mutation, errors of DNA kind of an argument, it's not as black and white as one would think.
There is a mutational burden issue, but most of what's there later was there at the beginning.
Yeah. I want to make a quick point, though, because I think Joe brought up a really important point, and that is, alluded to it, and that is, oftentimes when we see patients who are referred for smoldering myeloma, one of the most common things I do is say, I want to see you back in a month.
Right.
Because it's almost more important to know about tempo than it is to know about risk factors.
Yep.
And if it's that patient who's just passing through smoldering on their way to myeloma,
you'll pick it up.
You'll find it, and so offering them a smoldering trial may not have been the right thing to do.
Right.
Whereas if they're indolent, then you can offer some reassurances and enter them on one of these trials as appropriate.
Excellent. Okay, some very good points there. So let's move on to the second topic. And so a lot of interest in this as well. We have all these new options and new drugs. Has this, up to this present time, impacted frontline therapy? And so, considering both the US and Europe, you can come up with this kind of an algorithm. Patients who might be eligible transplant and those not. In the US, the options are relatively simpler for a number of reasons we can talk about. A number of different combinations are used in or considered in Europe. And then also the same is true over here in the non-transplant patients. We typically might think about RD, VRD, but other options are considered in Europe. But just to review the VRD data, the SWOG data is just was presented last year and is just being published right now as we speak in the Lancet, comparing VRD with RD, and these are your outcome measures. And so what has come from this comparison of VRD versus RD for this induction without frontline transplant is a significant improvement in both PFS, with a 16-month improvement in PFS and almost a 1-year improvement in overall survival. And so if you look at the curves here, those differences extend out. This is a long study that is real measurements out to over 6 years actually, and the same is true for the survival. So this has led Dr. Vincent Rajkumar in particular to come up with the Mayo team to propose this algorithm. And since you're part of the Mayo team, maybe you can start and indicate if you agree with this. So in the algorithm, what we have is actually the VRD selected in the non-transplant as well as in this transplant part of the algorithm, with options for frontline transplant or not, which we'll talk about later, with also this box here for the frail or the patients with comorbidity. So would you like to tell us first what you think about this algorithm?
No, absolutely. I think it's an excellent algorithm. I think in simplicity, we have a tremendous amount of evidence now for VRD, both in those going to transplant and those not going to transplant, because your SWOG study did include patients.
Covered both.
They're clearly not going in. So I think that's the general theme. And as you've outlined here, if we take those that are not going to transplant, we also want to be careful that as patients are getting older or have more comorbidities, we don't want to try and do a cookie cutter and have everybody treated the same. They might have more toxicity with this. And we do have very good evidence from the first study that RD on its own can be quite effective.
Yeah, so
what we might do in some of these patients is either consider RD or maybe what we sometimes call VRD light, where we give a milder regimen for the VRD. And then for transplant candidates, I would say indeed VRD is our standard of care, although a little controversial, but I think important. We've sometimes included KRD, so carfilzomib Lendex, in patients with particularly high risk or aggressive disease, or perhaps, not that that's a large proportion of patients, but patients who at the start of their diagnosis are already experiencing neuropathy, perhaps from diabetes or perhaps from the disease itself, that we want to, even with weekly subcutaneous use of bortezomib, we still see neuropathy. That will sometimes do that. But this is quite reflective of what we're doing in practice.
And so obviously we do have that KRD, VRD comparison going on with the ECOG trial, and it's not fully accrued yet, but so we will be getting those data. And then, although not such a strong option here, maybe you or maybe Sagar, you could comment, the other options could be VTD or VCD, the CyBorD regimen, which we sometimes would consider for various reasons. So what's your take on this algorithm?
Yeah, I mean, I think the approach of using a VRD-based regimen as the induction therapy for most patients is what we've been practicing for a long period of time, and we've sort of been going back and forth between institutions about that. So we certainly support that approach. I think that the non-transplant candidate, I'm going to change the name of that category.
All right.
And say it's the frail patient.
Okay.
Because if they're not truly frail, then they should be eligible for a transplant.
So they should actually be over here.
Yes, right.
Okay.
So for the truly frail patients, and I realize I'm changing the whole categorization.
No, that's okay.
But I can do that.
We moved the red boxes already.
There we go. I know. I'm moving it all, turning it upside down. So for the truly frail patient, I think the data really does support the use of RVD from large phase, or RD, sorry, from large phase 3 trials. The VRD light is very interesting. And certainly for patients that are at high risk, that might be something we do. But as we begin to see the data from ELOQUENT-1 and from the MAIA study that looked at either RD plus ELO or RD plus DARA,
Right.
that might be a really attractive triplet for the truly frail patient. So I think that the frail treatment approach is a little bit in flux right now.
Yeah, I would agree with that, yes.
Absolutely. Absolutely. I think we're all
Yes.
anticipating what it will be like to potentially add a monoclonal antibody to patients up front. And as you said, I think it's particularly attractive in the frail patient or the patient not going to transplant because the toxicity from those drugs don't seem to overlap very much with the toxicity that we have right now from RD, so that makes it sort of a natural partner. Whereas VRD is not always a perfect partner for those patients because it can be tougher on their blood counts and tougher on
Absolutely.
their systems.
But an accepted part of this algorithm right here is that there might be transplant. And so I want to move forward and say, well, actually, would you be doing the transplant? And so we've touched on transplant, no transplant, but let's look at the transplant data. And so obviously last year, one of the top presentations was the IFM data, the IFM DCI study showing the outcomes with VRD plus or minus transplant. And a lot of excitement about the fact that the remissions, the progression-free survival is obviously significantly improved in the transplant arm. How we have the second curve though, which is a p-value which is not significant all the way out, actually, and the timing gets to be important here. This curve you'll see is out here in the 3 to 4 year range, and those curves are still right there.
Yeah, the median follow-up is not 4 years.
No, it's...
It's shorter, yeah.
So anyway, we have the PFS, but certainly no survival data yet. And so the big excitement, I would say, and I would say talking to all of my colleagues, including I guess you guys, I think that there's a lot of anticipation for what is a late-breaking abstract tomorrow morning, 7:30, which is a large randomized study from the BTM-CTN group with Dr. Ed Stoudemire as the principal investigator, 758 patients in 3 arms. Those 3 arms are single transplant with consolidation, 2 transplants, or just a single transplant with all patients receiving the lenalidomide maintenance. And I think the shock to all of us, I think, is that using a 38-month evaluation time point, the outcomes show no differences at this point. There is no difference in these progression-free survival data. And so I think pretty stunning information, I would say, which kind of flies in the face of some other material presented at this meeting, and also some information presented at our last ASH meeting, indicating a value for tandem possibly in high-risk patients and maybe even beyond that. And so what we have now are 2 questions for you. And one is, do you still routinely transplant up front? And what is going to be your attitude about double transplant now? And so, do you want to take this one first?
Sure,
Joe?
absolutely. I think the data is convincing that transplant is still the standard of care in eligible patients.
Okay.
You showed the IFM DFCI data, pretty impressive difference in progression-free. I'm not as anxious about the overall survival. Not that overall survival isn't important. Who isn't into survival?
Right.
I'm into survival, but overall survival in an early stage trial like this is more reflective of subsequent therapies than it is the actual therapy. And the other study, of course, that is not quite as mature as the IFM DFCI, but almost identical design, was the trial out of Chicago, KRD plus or minus transplant.
Correct.
An almost identical like situation where even with very deep response with KRD, transplant was beneficial. As for doing double transplants or even consolidation, frankly, I mean, we haven't been doing a lot of it already, and I don't think we'll be doing much more of it. And I think this stamina study is very important, and it reflects the fact, in particular in the US, that with a VRD-like approach up front and a single transplant, the depth of response is so good that adding a whole lot more intensely right then isn't going to change the isn't going to change the situation. What's going to change the situation is keeping that maintenance on for a long period of time, which all 3 arms got here. So it kind of confirms, I think, what our gut feeling was, and it's, I think, reassuring to patients that going to a second transplant is tough on them. More intense consolidation can be hard on them. So I think a single transplant is the way to go, followed by len maintenance.
So what do you think?
So I think, this is a really hot button question amongst patients. There are patients who come in and say, I don't want a transplant from the outset. Or there are patients that will say, tell me about the pros and cons of one or the other. And the way I think about it is, we've got the tools right now to really make major impacts on long-term progression-free and overall survival. So when Ajay Nuka at our group looks at our median progression-free survival for all of our patients who got RVD up front with a transplant, it's close to 60 months. That's 5 years for first remission, right?
Right.
So that's a pretty substantial number. And I think that the other piece is there are subsets of patients that in 2016 we are curing.
Yes,
And
absolutely.
it's not a huge subset, but it's a
No,
subset, probably
definitely.
around 15 to 20%. And to not offer them an early transplant is perhaps denying them their access to that potential cure.
Absolutely.
So while I listen to patients when they say, I don't want to have my transplant now, and we've got a few rules about who can fall in that category, I will tend to encourage patients to have it, to give them the highest chance of being in that cure group.
Absolutely, absolutely. So I clicked back to this slide because you mentioned something which I think does become important, is that right now these numbers show here, you have these survival numbers with what we have, with VRD and then with transplant.
But 60 months is what I'm saying for PFS.
Yes, yes.
Right, as opposed to 46.
As opposed to 46.
Yeah, but with transplant?
Yeah,
Yeah, this is
Transplant
without
and
transplant.
that's what I'm saying. So you're losing PFS.
Right, right. And so I think that, and do you feel the same way about the impact for patients where the avoidance of the double transplant and the lack of a need for consolidation? Very good news, right?
Yeah, I mean, yeah, absolutely. The double transplant, I think, in many ways is a surrogate for access to the new combinations.
Yes, exactly.
So if you can get VRD up front, then you probably don't need a tandem transplant.
Exactly, exactly. But now, as you're saying, then you can move forward with these exciting new combos.
Yes, absolutely.
All right, so I'm going to switch to another topic and just a little bit of background to bring people up to speed. Basically, if you have a complete remission, what we now know is half of those patients are MRD negative, half of them are MRD positive. And so without that information, you're really working in the dark. And so if you have a look at the green curves here, the green curve is the patient who has MRD negative and CR, but without that, the patients fall down and have an equal outcome similar to just having a partial remission. So that MRD negativity really makes that difference. And so what we need is an integrated approach, and a lot of discussion actually at this meeting is that in this setting, not only do we need the MRD piece, but we also need the ability to immune monitor and assess, is it MRD negative? But also if it's MRD positive, maybe this could be a good risk patient because of the immune status, that we need those two pieces together. So we need to look at MRD negative, and then we need to be able to think about, well, what about the MRD positive? What should we do? Can we stop treatment? Should we change treatment? Very, very important questions. And so the new flow method called next generation flow does add this advantage, which by assessing 15 cell populations, shown with all these different colors here, you can tell if it's MRD negative based on the clonal plasma cells, which are up here. You can tell this is the myeloma, this is not the myeloma. But you can also tell if it's bone marrow. This is the red cell production, and then these are mast cells. If those are there, we know it's a good bone marrow sample. But over on the right here, we can see if there are normal B cells, normal T cells. What is the immune pattern in the bone marrow? And this is a helpful aspect of using this. One can also use the NGS very easily for the MRD testing, but this is an extra piece which is currently of quite a bit of interest. We've done a direct comparison here recently between those two methods. The other thing is that with the NGF, you actually do get information on all the patients. And actually, the NGF method is slightly more sensitive. If you have a negativity, this is NGF, but if you are negative by NGS, the sequencing or the flow methods, you have very, very good progression-free survival. So this is the backdrop to what we have. We have good testing. We have the ability to look at a number of aspects. We can design trials where we can look at MRD positive over here, MRD negative, stop treatment, change treatment, and we have a template here of the sort of trials that we're going to be seeing more of. Looking at adduction, consolidation, we can look at MRD all the way along, but we need to answer some of these questions over here as a top priority. So the questions for you are, how do you see the use of MRD testing moving forward? MRD negative, MRD positive. Maybe we'll take the top part first and then see how this is going to roll forward into clinical practice. So what's your feeling about MRD testing and clinical trials? What's the key need from your side?
Yeah, I mean, I think there's no question that understanding what to do with the information in the context of clinical trials is really important. And there are two ways to look at it. For the MRD positive patients, do you continue that same therapy or do you switch to something else to drive them to MRD negativity?
Right.
We don't know whether that actually changes the natural history of that disease. We presume it will,
Right.
but it's possible that it won't.
Right.
You know, just like there are patients who never achieve a complete remission, but actually do quite well because they have an MGUS-like state and you've
Right.
reverted them back to an MGUS-like state. So in those patients, you don't want to keep cycling through drugs saying you're not MRD negative, I got to try something else, when you may be throwing out good drugs, and they could be fine.
So you definitely see that as a key need, this kind of a trial,
Yes,
looking over
absolutely.
here.
In the MRD negative patients,
Right.
recall that even in the curves from the best trials with the longest follow-up, MRD negative patients are not in a plateau. They do continue to relapse.
Right.
And so understanding which patients are still at risk for relapse, and so you can't stop what you're doing,
Right.
versus which patients may be in that 15 to 20% cured fraction,
Right.
and you can stop.
Absolutely. Very important, yeah. So the typical question is, for example, in maintenance, and you become MRD negative, should you stop the maintenance? Well, I don't think we can answer that.
No, I agree. I mean, I'm actually very concerned that people might overinterpret the result of that, or almost equate MRD negativity to a form of cure or a pre-cure. We're just not there yet. And paradoxically, as Sagar has said, you know, we look at our Mayo database, for example, of long-term survivors. So those patients that have lived over 10 or even 15 years, there is that contingent, 15 to 20% of them, who actually have never had a complete remission.
Right.
So
Right.
we don't want to take that cookie cutter approach and say everybody's got to, you'll get MRD negative and you'll like it. We can't. We can't do that for everybody. But by contrast, I think we're starting to see it in the trials. And the one other thing I would add to the trial matrix that you put there is it seems in the highest risk patients,
Right.
MRD negativity is the most important.
Right.
Very,
Those
very
are the ones
important.
who don't go back to the MGUS state as much.
Right.
So that's where it's so important to get the
Right.
disease down. Because ultimately, you know, we're facing a bit of a crisis with the cost of therapies and the challenge and the potential toxicity of all these drugs together. This could be an interesting way of being able to say, we get you to that deeper response, and then we can take you off therapy. Maybe not cured, but perhaps someone can go on a long period of time off therapy. Almost like we did with diffuse large B-cell lymphoma. We built up a good cadre of drugs. We give the chemo regimen R-CHOP. 60% of people come off treatment after that.
Absolutely.
Because they're cured, or at least they're cured for long enough that they don't need immediate treatment.
Yeah, so a lot to learn, and as you were indicating in that MRD positive group, we need to define that, understand that, and so this parallel immune assessment can really help us with that, I think.
Absolutely, absolutely. I mean, but what I worry about is that it's no different than practicing clinicians who say, you haven't achieved a CR, I'm going to change your regimen.
Right.
You still haven't achieved a CR, I'm going to change it again.
Right.
And so that, again, you may be cycling through drugs, but not really getting benefit.
over-treating patients or...
So could I take you to this second question then? I'm sensing that, well, you can tell me. I don't want to prejudge what you might think for your second answer. So you want to go first on this one?
So I think what we do right now is for all patients at day 100, we
Yes.
check MRD.
Yes.
We also do a PET scan at that time point.
Yes, which is...
Because I think MRD is part of the equation when
Yes.
measured biochemically.
Absolutely.
But I think the imaging piece, as Bart has said for years, is
Yep.
actually an important piece as well. And then we check it at the 1 year and the 2 year and the annual
Right.
restaging studies. We use it more for information, as you
Yes.
mentioned, with careful education, but we don't necessarily make therapeutic decisions based on it.
Right, right. So how do you feel about
No,
this?
I completely agree. I mean, I think building databases to have this information is critical.
Yes.
But I think it's important that if the clinicians are listening or patients are listening tonight, getting that MRD status might contribute to our understanding of the disease and what may happen. But to say that we're making a decision to go or no go on more therapy or
Right.
stopping therapy, it's too early. It's too dangerous.
You don't want to give that implication.
Correct.
Correct.
All right. So our next topic is very broadly discussed, I would say, at this meeting. Even although the data were previously presented, we did have the follow-ups, which I would say didn't really show a lot. A little bit of follow-up data, but not a whole lot. But I think that what we're talking about is the combinations with daratumumab, with Revlimid and with Velcade. Really exciting data with the Pollux study, which is the one daratumumab Revlimid index, and then the Castor study, daratumumab Velcade index. And so my question that I'm going to be asking you moving forward is this really a game changer? I mean, are these data sufficiently better than what we've seen in the recent past to really make us think differently about the placing of the DARA combos? And so just to put the exact numbers on the table, so if we look at the information for the Pollux study, this is daratumumab Revdex versus Revdex, very good data, overall response rate 93%, and the thing that we've ended up focusing on is the top number, which is the hazard ratio for the difference for the PFS. So the length of the remission, the significance of the difference between the two curves. And this is a very low number, one of the, excuse me, one of the lowest that we've ever seen actually. Mm-hmm. And you can see that it's about half of the hazard ratio for the ASPIRE trial. Now, what we've also said in the past, that it's absolutely forbidden to be making these comparisons. Right. However, the fact that it is such a difference, I think we're starting to maybe reconsider this. I'll be asking your opinion on that for sure. And then if we look in the Velcade or proteasome inhibitor-based combinations, we have similar information, a very low hazard ratio, excellent results, better than with carfilzomib, in this case panobinostat and elotuzumab. On the Revlimid side, we had daratumumab, carfilzomib, elotuzumab, and ixazomib or Ninlaro. So, based on these data, the Mayo team have really put a decisive recommendation on the table, which I want to get your feedback about. And they said, well, it looks like those DARA combinations are really decisively good. And for this first relapse situation, they really should be considered as that first choice. And so, Joe, can you comment on this since it's coming from the Mayo team?
No, absolutely. I'm happy to do that. You know, I think you've said it well, Brian, that we can to some degree compare these trials. It's dangerous to push it too far. You know, as with each line of therapy in myeloma, there's less and less ease of consensus because so many other factors come in. We have quite a bit of consensus at this table and in the country on VRD up front and a transplant. As we start to relapse, it gets a bit more difficult. But I do think that these data are so impressive that including daratumumab at first relapse is very reasonable, very appropriate. Even the FDA, as you know, just a few weeks ago, has formally approved both of these combinations.
Right.
Now, when I sit down and look with a patient as to what they've been on, a lot of our patients are on lenalidomide maintenance, So the DRD isn't really a great option, although we sometimes might consider it. So we're more often in that refractory to lenalidomide where we can look at multiple options. But the fact that the monoclonal antibodies work so well,
Yes.
have really a lot less toxicity, except maybe on the wallet, but I think is
Yes.
actually, when we'll come to that, I'm sure, I think it's very appropriate to take this kind of approach. I think it's hard to make it just one regimen. We always have to look at the other
Sure,
options.
all the others
There are
there,
times
but-
that we might use carfilzomib, there are times that we might use ixazomib, but in general, bringing the monoclonal antibodies early on, absolutely.
Yeah, so I think that this is a good segue to you, Sagar, because if we go back to this chart, if we go back to this chart here, the ELO, the Eloquent study,
Right.
as the principal investigator of this trial,
Right.
I think that it's important for you to comment on the choice of the ELO combo, and
Sure.
how do you view this?
Yeah, I mean, I think that we can make sort of blanket recommendations, but the reality of many of these decisions is that there's a lot of factors that go into it. How far does the patient live from your clinic?
Okay.
What is are they working? In which
Yep.
case, coming in once a week or twice a week is a real challenge.
Right.
You know, are there quality of life reasons that they'd rather be on an oral approach or a once a week or a once a month kind of infusion schedule?
Right.
Those all play into it. And so what we do is really think about, are they len sensitive or len refractory, as you showed there? Most of the trials with those really great or average hazard ratios, depending upon how you look at it, were done in a len naive patient population. And so the fact that almost all of our patients are going to be on len maintenance now means that extrapolating these 4 data pieces to those patients is not exactly one-to-one.
Right.
And so for the patient that has a very indolent biochemical relapse on len maintenance, we may consider adding in IXA and DEX. We may consider adding in ELO and DEX as a way to sort of get
Right.
as much as you can out of all the drugs that you have available. If they don't fit one of those 2 categories, then our standard salvage would be to use pomalidomide plus daratumumab,
Right.
because they're a lenalidomide refractory patient.
Yes, exactly. So see, in this algorithm here, if you will, I think that you just said that with patients more likely to have become refractory to
Right.
lenalidomide, we might be looking at the Dara-Velcade combo, or as you say, pomalidomide.
Right, right.
And so,
And you know, some of that is chosen from a convenience issue for patients, you know, not having to come in once or twice a week, depending upon how you do the
Right.
bortezomib, is really a quality of life issue. And we've been really struck, and I know you have as well, by the POM-DARA interaction. I mean, POM
Right.
is clearly a more potent immunomodulatory agent.
Right.
It works in 17p deleted patients.
Absolutely.
And so in some of our early relapses with high-risk disease, that's been a really effective salvage regimen.
yeah, so we could see some significant evolution here, where that right box there could actually become Dara-Pomdex, because
Yeah.
so much
Right,
Revlimid has
right.
been used.
That's the difference between M-SMART and E-SMART, evolution.
Evolution, there you go.
Well played. Well played.
All right.
Score 1 for Lonial there. I'll give
Right,
him
right. So obviously it's going to affect all of the options moving forward. You know, you
Right.
could have some other options and
Yeah,
then additional
yeah.
options that we're going to have to
And I think it's just so
consider.
important what Sagar said around looking at a patient individually.
Yes.
Risk status may make
Yes,
a difference. If a
absolutely.
patient has translocation 414,
Yeah.
I probably won't reach for POM, but I'll
Correct.
reach for
Yes.
carfilzomib or bortezomib if
Absolutely
they're not
right.
resistant to it.
Absolutely.
The travel issue, the frailty, and to be blunt, now some of our
Yes.
patients, some of the oral drugs
Yeah.
are coming with significantly higher copays.
Right.
Despite all
So
the
the- so
efforts
the
that we have.
financial
And I
aspects.
recently had a patient, it was very hard for them to go on ixazomib, lenalidomide, dexamethasone,
Yeah.
because the copay for each of the 2
Right.
was maybe reasonable, but the 2 together was not possible. So
Right.
we had to think
Think about
creatively
all
of a
of
different
those.
regimen.
And so I'm showing you a table here which was presented by Philippe Moreau at our satellite session. And just to emphasize, in the middle of the table, you'll see the minimum clinic visits that are required for a particular regimen. But we're looking at the burden of the particular regimen to the patient. Clinic visits, the scheduling and the route of administration, all these kinds of things. And so ultimately, you know, as you're saying, we need to be looking at all of these
Yeah.
things. Yeah,
Agreed.
very
Yeah.
important.
Yeah, I mean, algorithms are really nice, especially in cancer. But,
but-
the reality is we treat patients.
Yes,
Absolutely.
and you got to figure it all out on an
Right.
individual basis.
Right.
Absolutely.
All right. So I think that, as I said at the beginning, tremendous interest in when you go home, when we go home, the patients say, okay, what was the new drug you learned about this year, right? So what I'm going to go through and summarize with you is what my take was, and then you can tell me what your take was, all right? So the abstracts that were this year that I selected, this was, I would say, quite an unusual and unexpected abstract from a new Swiss team that we don't normally see working in our myeloma trials. And they put forward this result using 34 patients resistant to Velcade, and based on some indications that giving, along with the Velcade, an age drug, a protease inhibitor combined with a proteasome inhibitor. Very confusing. But they have preclinical data indicating a synergistic effect, overcoming of the resistance, and the combo was reasonably well tolerated. Questions were asked. It seems that these patients were indeed refractory with a very interesting response rate of 65%. They also showed this cascade plot with some pretty deep responses over there. And so very, very interesting. And maybe we'll just take these new drugs individually. Sagar, so what was your take on this?
Yeah, I mean, so we've actually got a scientist who's been trying to get us to do this for a couple of years at our place.
All right.
And it really all has to do with glucose metabolism within the tumor cell.
Okay.
And that by using the protease inhibitors and or metformin,
Yeah.
you can actually significantly alter the Krebs cycle. I mean, that's the simple way to put it, right? I mean,
All
there's a lot of complicated enzymes in there, but you can modulate metabolism within the cell and shut it down, and then when you bring in ER stress from a proteasome inhibitor, they all fall apart. So we've resisted a little bit despite the really, really interesting clinical data. What struck me about this was first the response rate, as you show here.
Yes.
But then when you start to look a little bit more at the details, the median number of cycles that patients got was 4. Now, the max per protocol they could get was 6, and that was a cost issue. But if 2/3 of the patients responded, why didn't 2/3 of the patients get 6 cycles? Right? We're not exactly sure how that worked. And
Okay.
there was a lot of heme toxicity.
Yes.
50% of patients had grade 3, grade 4 thrombocytopenia. Significant number of patients had neutropenia. So these drugs are not benign without
Right.
their own added toxicities. And I think what the presenter said that actually I completely agree with is we need additional follow-up or we need additional data, meaning another trial,
Right.
to sort of validate this concept.
Yeah, that's pretty much what I heard. Everyone said, this is really intriguing, but let's do another study to validate and see what's going on here. So,
Completely agree. Don't have much more to add apart from the fact that, you know, for a number of years we've had a lot of work in the lab that seems to validate this. And I think that's why
Yep.
it gained a little bit more credibility with me because of what we had seen from a scientific side. But I agree, there's some unanswered questions. Remember, it's not a massive study with lots of
No.
patients, but clearly enough signal to test this a bit further because wouldn't it be great if we had a different class of agents here to add to our current growing groups of classes of agents for myeloma?
Yeah.
absolutely. So, very interesting, very intriguing, certainly new.
Yeah.
Now, venetoclax, the Bcl2 inhibitor, exciting data here. This is the single agent, also combination data. We did hear about this a little bit last year, but I think that these are more decisive data this year. Shaji Kumar presented the single agent data, relapse refractory disease, and this is amazing that in the 11-14 subgroup, the patients who have what we could call a favorable Bcl2 pattern, so in other words, they are the most susceptible to the inhibitor, the results are still pretty dramatic with a 40% overall response rate with some pretty deep responses in there as well. And in discussions, I know actually you commented, I guess you have one of the patients in this trial who's done extremely well. Is that right,
Yeah, we
Sagar?
have several that had gone through all available therapies, didn't really have anything left, and when we saw that patient as a consult from quite a distance away, the marrow came back 1114, and we said, and we actually took a sample up to the lab. So Larry Boyes at our place has got that whole profiling that you mentioned for sensitivity. He can do that in a 12-hour assay, and predicted that this patient would be highly sensitive to the drug. She was the second or third most sensitive patient we'd seen, and we'd profiled 50 or 60 patients. She rapidly went into a VGPR and is now MRD negative for close to 2 years now with one drug.
Pretty strong advocate there. What do you think, Joe?
Well, I'm an author on this paper, so
Okay,
maybe be careful what I say. But you're absolutely right. I mean, I have 2 patients who literally were deciding between hospice and going on to the trial because they had failed carfilzomib, Pomdex, one of them, and now been on the study for 2 years. So it seems to me that although it's a little bit of a, if I can call it a boutique area, translocation 1114, which happens in 15-ish% of patients if it's done correctly. For that group of patients, it can be very effective. But as you know, the other study with venetoclax presented with bortezomib was perhaps validating it along with bortezomib in more than just the 1114, because even the non-1114s did better, whereas here in our single agent study, the non-1114s really only had about a 6% response rate, so it was quite minimal. But with the combination with bortezomib, which you have here, that Philippe Moreau presented, I think we saw a much stronger signal. And not a big shock scientifically based on how a proteasome inhibitor works and how this Bcl2 inhibitor is working. I think we are not shocked to see this kind of synergy, although maybe the results were a little bit better than we anticipated. So I think this is actually going to be a veritable target drug that we're going to hopefully see available to us in the not so distant future. It's already proven itself in leukemia, in chronic leukemias, it's proving itself in lymphomas. Myeloma might join that fold shortly.
Yeah, I mean, I would take it almost one step further and say we've done a lot of work on deep sequencing and all sorts of molecular profiling of patients in all different settings. This, with FISH, is the closest we've gotten to precision medicine in myeloma.
Right. So Joe, let me ask you this with that point. What is the approval path for this drug? Is this a drug for the 1114, as you're saying, a precision approach? Do you see that as
well, if you look at just our single agent study, that would have been it. But this study here makes me think that maybe there is a broader net for the drug when combined with bortezomib. I think that perhaps the fastest pathway could be just in 1114, but then it's restricting it to that 15% of patients. This I think validates it in a further context that if they could do a bortezomib venetoclax versus bortezomib study and show that signal to be that strong, then I think they have a path to.
So I agree with that actually. I have to say.
And the other quick point to make about this drug, it's oral. It's quite well tolerated. I mean, every drug comes with, unless it's mother's milk, everything comes with some toxicity and risk, but most of our patients on this study are tolerating it quite well. It doesn't come with a lot of the side effects that we see with other myeloma drugs in terms of neuropathy or significant drop in the blood count. So that's been very encouraging. So in future, I suspect it might be an interesting partner with other agents, not just with bortezomib.
Yeah, very, very good. Yeah, so very promising. And this is certainly exciting stuff to report back to our patients. So for the selinexor, again, this is a drug that's been presented actually for 2 or 3 years now. This is a unique mechanism of action involving the oncogenes and the nucleus. And so we have actually a total of 4 trials presented with selinexor. And so this first one, I don't know where they come up with these acronyms, but the STORM trial is selinexor combined with Dex. 79 patients, and they were looking at the quad and the penta refractory. So these are patients very, very heavily pre-treated. And so my first question to you, Joe, I guess maybe start with this one is 21% response rate, 20 for the penta. So how does this strike you? Is this Is this?
This strikes me very strongly. One,
Okay.
we were participants in this trial.
Okay.
I've had a number of my patients go on this. In fact, I think this was a good story of collaboration, working with a company to say to them, the true unmet need in multiple myeloma might not just be people who have seen these drugs, but patients who are actually truly refractory. We had to prove refractoriness to each of these drugs. So, for example, if someone had had VRD, a transplant, and then lenalidomide maintenance and progressed, they're not refractory to bortezomib. They're
Right.
only refractory to lenalidomide. But in that situation, when you're refractory to all of those 4 drugs, and then later on we added the cohort of being refractory to the CD38 monoclonal antibody,
Right.
where there was daratumumab,
Right.
some of these
The
were
5.
cetuximab. 20% response rate, to me, this was very, very significant. This could well be the next drug available to us in myeloma. And in fact, the fact that it was 20 and 21 between the quad and penta further, I think, validates that it's coming from a unique mechanism. I think the challenge with this drug earlier on that we've overcome mostly was the GI toxicity. In the
Right.
early days, people really didn't want to eat anything. They had horrible
Yeah.
nausea. People were getting weight loss. There's a small subset of patients that have a salt metabolism problem that get really low sodiums. But now that we've sort of aggressively managed that from the start, watch for it and intervene, now the majority of our patients can actually take this agent. And it's a pill, so it's
Right.
conveniently given. So I really think the fact that it's proven itself on its own to get its own invitation to the party
Yes.
is a big deal,
Big
but
deal.
then it's going to be a natural partner to others as well.
Right, and so just the other thing is that, as I understand it, the side effects seem to be strangely even a little better with the combos.
Right. That's the. I think so. There are 2 points here. One,
Yes.
we're already seeing the impact of DARA on trial design for new drugs.
Yes, absolutely.
Because they had to create a new category where they
Right.
were DARA resistant.
Right.
And I think we're going to see that in many, many other new drugs that are coming down the pike as
Right.
well. The second point, I think, is that, as you mentioned, the anorexia, the lack of appetite, the fatigue, and the nausea really are some of the biggest issues that we saw. The Dex helped a little bit because it was probably more so in the selinexor alone category. But I would actually almost argue from the data we saw at the meeting, combining selinexor with both bortezomib and carfilzomib, that the best antiemetic for selinexor is not Zofran, it's a proteasome inhibitor, because it really
Yes.
did make a lot of those symptoms better.
Absolutely, this
Yeah.
is what I was referring to. So
Yeah.
that in the
Stop.
combinations, we have Velcade, we have pomalidomide and carfilzomib, and exactly, it seems that the toxicity is much less, and the responses are really
Yes.
quite good.
Yeah.
And so this is the alternate approval pathway. Is what is the next trial coming up?
Right.
The randomization
Right.
in the STOMP trial, the Boston trial.
The Boston trial.
Boston trial, yes.
Selinexor, bortezomib dex versus bortezomib dex.
Okay, yes. So it sounds to me that you both are looking on this reasonably favorably,
Yeah.
and be keen to see those results.
Absolutely.
Yeah.
Absolutely.
Okay. So actually, this is the last abstract or kind of collection of abstracts that I picked that are being presented or have been mostly presented at ASH this year, the CAR T cells. And so for those not familiar with CAR T cells, these are the patient's own cells, which are engineered and directed against the myeloma, picking different CAR targets. And so in this case, the target is CD19, which actually can be present on myeloma, and we can talk a little bit about to what extent it was actually even present in these patients, but giving T cells that are targeted against the myeloma to see if this can wipe out the myeloma. And at this meeting, we saw also a BCMA target, a B-cell targeted approach, and then even an antibody approach. And so if we look at those three, you have the CAR T against CD19, against BCMA, or even an antibody. How do these results strike you? We have here, obviously it does not work in every patient. There were 3 long remissions right here. And so there is a lot of, I would say, hype about this. There's a lot of expectation that this can be a really good treatment Maybe you want to start us off on this. So what do you think about these CAR T cells?
Well, I think I share people's excitement, but I also think it has to be put in the right context. I think as scientists, we get like all hot and bothered about things like CAR T cell therapy, and it's all exciting because we're manipulating T cells and we're directing it back to someone's myeloma. It's under the umbrella of personalized medicine. It's very unique science. It's the kind of thing that makes the cover of the newspaper or Time magazine. And I think it's very exciting because in some other fields, in particular in certain leukemias, where people have no other option, where they're pending death, sadly, I think it's very much validated itself. The reason why I'm a little bit more cautious in myeloma is two things. One, I'm not sure we've come up with the perfect target yet. I'm not sure CD19 is absolutely the ideal target. I think BCMA is moving that direction, and the antibody that you mentioned is maybe even moving a bit more in that direction. But the second thing that concerns me a little bit, Brian, honestly, is this isn't easy therapy. I have patients coming into the clinic saying, oh, I can get CAR T cell therapy, can't I?
Yes.
This is worse than a transplant. I mean, these patients get really quite sick. We've had some deaths, as you know. The FDA has put some of this work on hold and consideration because of it. I thought today, sitting in one of the abstract sessions, if this were just a novel drug and someone was standing up and saying in the 10 patients they treated, one died, one went to the ICU, we would all say, wow, we really need to step back. So I think we need to apply the same rules to new drugs as we do to new modalities of treatment like CAR T cells. So I hope I'm not scaring people. But I do think that we need to be cautious about something that might sound Star Trekian and exciting and wonderful, but can also really hurt people. So I want to be very cautious around this thus far.
Right. So maybe, Sagar, you could put it in perspective. You hear these cautions. So we have the cautions about the therapy itself, and then to kind of put it in perspective with all of the other evolving and novel therapies. So what's your take?
Yeah, I mean, I think, what's really interesting about the CAR T cell approach is that it has been very much in the news. Everybody's really excited.
Yeah.
It's phenomenal science. And I think the way that things are being done from a delivery of therapy aspect, it is sort of cutting edge. It's as cutting edge as you can get. But I think the real question is, of the people that need this kind of therapy, what fraction can actually get it?
Right.
Not because they can't get to a center, it's how many can actually get the cells delivered to them.
Yes, and also have a transplant potentially.
Correct, right. So I think it's a complicated process, and as scientists, we should remain somewhat methodology agnostic.
Yes.
Meaning that if we have tools to treat our patients, then we want to use them in the best way we can. So if you pick BCMA as a specific target, which I would think from an immunotherapy perspective is probably the best target in myeloma.
Okay.
It's almost only exclusively expressed on plasma cells. Every other target we've used, including DARA, including ELO, including CD19, is expressed on other less mature B cells. BCMA is almost only on myeloma cells.
Right.
And so we have three different ways to attack it. We can do it with a monoclonal antibody that has an antibody drug conjugate. That was presented at this meeting, 60% response rate, single agent.
I know.
We can do it with a bispecific or a BiTE antibody, also a way of engaging the immune system and getting responses.
Right.
Or you can do it with a CAR T cell.
Right.
Let's see the data in terms of response rate and durability of response, and then make a decision on what's the best way to go.
Absolutely, absolutely. So I think we've kind of covered this here a little bit, and so I'm going to go to what is our last slide, just to kind of think about having been here at ASH and, realizing that we're seeing some old therapies again, some new ones. What was the most important one or two things that you learned here at ASH this year, or are expecting to learn with this late breaker tomorrow?
One, I would say fewer, if any, second transplants and consolidation therapy. So maintenance lenalidomide is enough.
So big piece of information there.
Two, DARA combos are truly validating themselves and coming up earlier. And three, I'd like to see selinexor and venetoclax get to the clinic sooner than later.
Okay.
Maybe if you wanted a bonus.
Yes.
CAR T cell is getting close, but I'm still a little bit, and I agree with Sagar as to what he just said, I'm not jumping totally on the CAR T cell bandwagon. if anything, it's probably a really small bandwagon for a few people that it may very much be helpful for.
Yeah, I mean, I think for me, obviously, I think everything you've described is right on. The ability to finally target and enhance immune function
Okay.
against myeloma is something.
This concept.
We've talked about it in cancer therapy for 40 years, and nothing ever happened.
Right.
Now we finally have the tools to be able to do that. And when you think about, yes, bites, CARs, all that other stuff, but the pembrolizumab data was pretty impressive.
Yes.
Not just the response rate, but the durability. That
Right.
PFS was 4 times longer than what we saw, actually 5 times longer than what we saw with Pomdex alone.
Right.
So the response rate may not have knocked you off your socks, but certainly the PFS was really quite impressive. And that's the strength of immune
So that
therapy.
true immune modulation is
Yeah.
a key aspect. Going
Yeah.
back to that MRD and the
Yep.
immune modulation,
Absolutely.
very important to understand it and to enhance it as much
Yep.
as we can.
Agreed.
All right, well, we've covered a lot this evening, and I'm really grateful to you both, especially Sagar for jumping in at the last minute. And so,
He makes a pretty good Marie-V.
yeah,
doesn't he?
yeah. Well, I mean, you got to work on your hair, though. But
Yeah.
anyway, so I think that we're really, really pleased that you've joined us this evening, and we really hope that we've given you some exciting new information. We are certainly trying to give you the flavor of what has been going on here in San Diego. So thanks again.
It's a pleasure.
A good evening to everyone, and we will be looking to seeing you again next year. So thank you all.